Welcome to this video where we delve into the intricacies of immunotactoid glomerulopathy, a rare and fascinating disease affecting the kidneys. Join us as we explore its causes, how it damages the kidneys, common symptoms, diagnosis, treatment options, and the latest research advancements in this field. The exact cause of immunotactoid glomerulopathy, or ITG, remains largely unknown. It's classified as a type of glomerulonephritis, meaning inflammation of the glomeruli, the tiny filtering units within the kidneys. However, unlike many other forms of glomerulonephritis driven by antibodies, ITG is associated with organized microtubular deposits. While the precise trigger is elusive, several factors are thought to potentially play a role, including underlying hematologic disorders like monoclonal gammopathies, autoimmune conditions, infections, and even certain cancers. It's important to note that in many cases, no clear associated condition is identified, making it an idiopathic or spontaneously occurring disease. So, what happens inside the kidneys with immunotactoid glomerulopathy? The key lies in the abnormal deposition of organized microtubular structures within the glomeruli. These structures are often composed of monoclonal or polyclonal immunoglobulin, most commonly Ig. These organized deposits cause inflammation and damage to the glomeruli. This damage disrupts their filtering function, leading to proteinuria, meaning protein in the urine, and hematuria, or blood in the urine. Over time, the progressive glomerular damage can lead to chronic kidney disease and eventually kidney failure. The unique organization of these deposits, appearing as microtubules under electron microscopy, is what distinguishes ITG from other glomerulonephritis types. Immunotactoid glomerulopathy is considered a rare kidney disease. Precise prevalence and incidence rates are difficult to determine due to its infrequent occurrence and potential for misdiagnosis. It affects both adults and children, but is more commonly diagnosed in adults, typically in their 50s and 60s. While it affects individuals of all ethnicities, some studies have suggested a possible slight predisposition in certain populations. Due to its rarity, large-scale epidemiological studies are challenging, making it crucial to increase awareness and improve diagnostic accuracy. The symptoms of immunotactoid glomerulopathy can be varied and often overlap with other kidney diseases. Many individuals may initially be asymptomatic, with the condition detected during routine blood or urine tests. Common signs and symptoms include proteinuria, which can lead to edema or swelling, particularly in the ankles and around the eyes. Hematuria, presenting as red or tea-colored urine, is another frequent finding. As kidney function declines, patients may experience fatigue, high blood pressure, and symptoms associated with chronic kidney disease, such as nausea, loss of appetite, and difficulty concentrating. In severe cases, kidney failure can occur, requiring dialysis or kidney transplantation. Diagnosing immunotactoid glomerulopathy requires a thorough evaluation. The process usually starts with abnormal findings on routine urine and blood tests, such as proteinuria, hematuria, and elevated creatinine levels, indicating impaired kidney function. The gold standard for diagnosis is a kidney biopsy. A kidney biopsy allows for microscopic examination of the kidney tissue. Under light microscopy, the glomeruli may appear enlarged and inflamed. However, the definitive diagnosis relies on electron microscopy, which reveals the characteristic organized microtubular deposits within the glomeruli. Immunofluorescence studies are also performed to identify the specific type of immunoglobulin present in the deposits. It's also crucial to rule out other similar kidney diseases through comprehensive clinical and laboratory assessments. While immunotactoid glomerulopathy is generally considered a single entity, some researchers classify it based on the immunoglobulin type found in the deposits, such as IgM or IgITG. The most common type is IgITG. Further classifications may consider the presence or absence of an underlying associated condition, such as monoclonal gammopathy, leading to categories like idiopathic ITG or ITG secondary to a specific underlying disease. However, these classifications do not necessarily translate into distinct clinical presentations or treatment approaches. The treatment of immunotactoid glomerulopathy focuses on reducing inflammation, suppressing the immune system, and managing the complications of kidney disease. Treatment strategies often involve immunosuppressive medications, such as corticosteroids, cyclophosphamide, or mycophenolate mofetil. Rituximab, a monoclonal antibody targeting B cells, may also be used, especially in cases associated with monoclonal gammopathies. In addition to immunosuppression, managing proteinuria with medications like ACE inhibitors or ARBs is crucial. Controlling blood pressure, addressing edema, and managing other symptoms of chronic kidney disease are also important aspects of treatment. In advanced cases of kidney failure, dialysis or kidney transplantation may be necessary. Unfortunately, there is currently no known way to prevent immunotactoid glomerulopathy, primarily because the underlying cause is often unknown. However, early detection and prompt treatment of associated conditions, such as monoclonal gammopathies or autoimmune disorders, may potentially reduce the risk of developing ITG in susceptible individuals. Regular checkups, including urine and blood tests, can help identify early signs of kidney disease and allow for timely intervention. Maintaining a healthy lifestyle, including a balanced diet, regular exercise, and avoiding nephrotoxic substances, can also contribute to overall kidney health. The prognosis of immunotactoid glomerulopathy can vary widely, depending on the severity of the disease, the underlying cause, and the response to treatment. Some individuals may experience stable kidney function with appropriate management, while others may progress to end-stage renal disease. Recent research efforts are focused on understanding the specific mechanisms driving the formation of the microtubular deposits and identifying novel therapeutic targets. Studies are investigating the role of complement activation and exploring the potential of targeted therapies to disrupt the immune pathways involved in ITG. Furthermore, advancements in diagnostic techniques, such as improved electron microscopy and molecular analysis, are enhancing our ability to accurately diagnose and characterize this rare kidney disease. The future holds promise for more effective and personalized treatment approaches to improve the outcomes for individuals with immunotactoid glomerulopathy.